Pain after laparoscopic cholecystectomy needs multimodal analgesia for complete pain relief. Various causes of pain after laparoscopic cholecystectomy are peritoneal stretching and diaphragmatic irritation by high intra-abdominal pressure that is caused by pneumoperitoneum or by carbon dioxide absorption from the peritoneal cavity. Multimodal analgesia is a pharmacologic method of pain management which combines various groups of medications and modalities. For these blocks, we have prepared 40 ml of 0.25% levobupivacaine with 1 mg butorphanol, which is an opioid analgesic, in 2 syringes of 20 ml each. One 10 ml syringe we have filled with normal saline to do hydrodissection and to confirm the correct position of needle. Normally, echogenic needles are used to give the plain blocks, but due to non-availability of these needles, we will be using 23 gauge Quincke spinal needle. The central portion of the anterior abdominal wall is innervated by the ventral branches of the T7 to T11 spinal nerve roots. These ventral branches lie between the rectus abdominis muscle and the posterior rectus sheath. We have used high frequency linear transducer. For rectus sheath plain block with the patient in the supine position, the linear transducer is placed in a transverse orientation approximately 1 cm above the umbilicus in midline. Scanning is done to linear semilunaris is identified. Now scanning is being done to identify the rectus, right-sided rectus abdominis muscle and the posterior rectus sheath. Now the needle is being introduced. As we can see the entry of the needle in the in-plane technique. So we can see that the needle is being introduced. And now it has pierced the rectus muscle. Hydrodissection is being done to confirm the position of the needle with 2 ml of saline. After confirming the position of the needle with hydrodissection, we are going to deposit the 10 ml of drug, that is levobupivacaine with butorphanol, in right-sided rectus sheath plain block. Now after doing the right-sided plain block, we have scanning the left-sided rectus sheath muscle and the plane between the left rectus muscle and the posterior rectus sheath of the left side. We can see the position of the needle, and we will be confirming the correct position of the needle by doing hydrodissection with 2 ml of saline. Now we will be depositing another 10 ml of 0.25% levo with butorphanol. We can see the hydrodissection and the spread of the drug in this plane. We can see the spread of the drug also in this plane. Now coming over to the tab block. The tab block was first introduced by Rafi in 2001 as a landmark guided approach via the triangle of Petit to achieve a field block. It is situated between the iliac crest and subcoastal margin. The base of the triangle is formed by the iliac crest, and it is bounded anteriorly by the external oblique muscle and posteriorly by the latissimus dorsi muscle. Tab block involves the injection of a local anesthetic solution into the plane between the internal oblique and transversus abdominis muscle. For the tab block procedure, linear transducer is placed 2 cm inferior to the xiphoid process. The rectus abdominis muscle and fascia are identified. The probe is moved inferolaterally from the xiphoid to the anterior superior iliac crest over the oblique subcostal angle. External oblique, internal oblique, and transversus abdominis muscles and fascia are located. The needle is inserted into the plane between the internal oblique and transversus abdominis muscle. Hydrodissection done with 2 ml of normal saline, followed by injection of 20 ml of 0.25% levobupivacaine with 0.5 mg butorphanol. The subcoastal tab block provides analgesia by blocking the anterior cutaneous branches of the intercostal nerves with nerve roots ranging from T7 to T10, and it will also provide analgesia to the drain site also.